I'm going to share my screen. Hi, Simone.
Hi.
Good afternoon, good evening. I can't see you.
Hold
Are you
on.
okay? Are you okay? Still at
Yeah.
work? Still at work?
No, not yet. Almost. I'm heading home in a few.
What time do you close?
It varies.
Okay. I can always adjust the time, you know. Just let me know.
Okay.
Can you see my screen?
Yeah.
Oh yeah, I just saw your message. I thought I admitted you in and I kept calling your name until I saw that. Okay, so the quote for the day. This is just a motivational quote. It's not part of our studies today. Did you hear what I said about the Google Classroom assignments? Hello? Can somebody hear me?
Yeah, I can hear you.
Yeah.
Okay.
We're hearing.
Yeah. So did we get to review the document that I sent in Google Classroom?
I looked for.
You say?
Yeah, maybe I was able to go through.
You're able to go through it?
Yes.
Patience, give me 5 minutes. I'll be right back, okay?
Okay, sure. Okay. And Freddie, how was it? What do you think?
Don't like to use the
It's good.
Does it
It's
give
very
any
good.
information? It's
Yeah,
like
yeah.
final moment learning.
Yeah.
It's just I have a bunch of them and
That's
I'll be
the only
sending them as
thing.
time goes.
Okay.
I don't want to
Indeed.
send too much
And
and
just
then
a minimum if
you have too much to learn
know,
and you are slammed. But
okay,
if you
we
think you
need
need more, just let me know.
tenants.
Okay. Ready. So before she comes, can we continue where we stopped the last time?
Yeah, we can.
Okay. So the last time we just finished about blood. The next topic I wanted to move to was acetylsalicylic acid, which is aspirin. Okay. So I have it that what are the indications to give aspirin? When do you need to give a patient aspirin?
You can't go by those. Let me tell you
Aspirin, no.
Also,
For pain count.
You say?
You can give aspirin for pain and also for fever, something like that.
For fever?
So for pain, it's maybe number one.
For what? I can't hear you. Can you hear me? Hello? Friday? Can you hear me?
Hello.
Yeah.
Hello.
You said for pain?
Aspirin has an antiplatelet property, so also act as a blood thinner, something like that.
Okay. It's an antiplatelet medication. So it also has a little property that that can cause blood bleeding. So that's like a blood thinning cross effect. So it is usually given for mild to moderate pain. Mild to moderate pain. Can you hear me?
Yeah, I can hear you.
Okay.
Sorry.
It's hard when you're talking and you don't know whether the person is hearing or not.
Yeah, I can hear you loud and clear.
Okay.
That's that norm. Because right now, studio cramping is more fun.
One second. Clementina is having difficulty joining. I'm trying to get her the link.
Yeah, I can see her on the link.
Yeah, she says she's having trouble joining. Okay. Freddie, this one, you are closer to the exam. That's why I'm going through all those things. They are just short reminders. When you sit by the exam, sometimes you don't get to study all that. When you sit at the exam, it's like your mind goes, I always say my mind goes blank and they laugh at me. It's like your mind goes blank. But when you see the item, the name of the item, you will remember it somewhere you have ever met it or somewhere you have ever studied it. Now on the NCLEX, there are some words you need to take note of. We have some words like assessment findings. So when they say the assessment findings that the nurse had, or what are the assessment findings for the nurse to look out for, is the same as when they ask you what are the signs and symptoms to look out for. So there are some words that they use them interchangeably. When they ask, what will the nurse do? What is the intervention for this and that? The other form to ask that question is, what will the nurse do? So what you are doing will be the intervention. So it's another form of asking NCLEX questions. So you have to be careful. Don't let the words confuse you when they use all those words. To instruct a patient, to teach, to educate, all those things are the same thing. It is the role of the nurse. The LPN will reinforce teaching. And then if in the case of an LPN writing the exam, that means you carry all the workload on yourself. So when they ask you assessment, you can only go back and assess and gather information after an RN has assessed. Initial assessment, initial patient admission assessment is basically for RNs to do. But the LPN too, being a nurse on the floor, also have a role. You only assist, and the expectation for NCLEX is for you to also know the right thing. So, Freddie, let's go back to the thing. Simone, if you come back, let me know, okay? What's this?
Okay.
You are back? Okay, does aspirin increase or decrease the effect of methotrexate? Do you know methotrexate? Freddie.
Please, can you repeat what you said? I'm sorry.
Does aspirin increase or reduce the effect of methotrexate?
Aspirin, what I know is it prevents further bleeding, further blood clotting. So,
And what is methotrexate in the first place?
well, it's used to control the medication is, it deals in the bones and those things.
It deals
Hold
with
on.
the bones?
Hold on.
But you see,
Because I know you are
you're
almost
not
going.
sure. Then I shouldn't put in the offer, because if I put in them the offer, hello, Cameron.
It's
Okay, their house, right? Their
it's like
the top
immunosuppressive
how
medication.
many bedrooms?
Mhm.
So
Wait,
And
wait.
how does that work?
But
with
what I
aspirin?
know is
At the very top.
they use it to control cancer and those things.
I'm sorry, I didn't.
So how does
So
that work? with
it will have
aspirin?
it. How it's gonna work with aspirin?
Mhm.
The basement different. The first floor where we went has,
How does that work?
It will cause severe bleeding.
and then the second floor has how many bedrooms?
Okay. So methotrexate is a type of disease
And the third
anti-rheumatic medication. It's like a medication that helps reduce inflammation. So just like we have the NSAIDs in another form of it, methotrexate is a form of anti-rheumatic medication. It can be used in cancer patients. It can be used to reduce pain for cancer patients as well. So it also has a bleeding tendency. So if the patient is taking aspirin and you give methotrexate, it can cross affect, and then the patient can have more bleeding. So it's an anti-inflammatory agent for rheumatic disorders. So like rheumatic arthritis, rheumatic fever, cancer, leukemia, those things are inflammatory. So you use methotrexate for them. Okay. So given that with aspirin will
And there's a
increase
separate entrance for the
to
third.
increase the effects
So
of the
technically,
medication.
it's
Doesn't,
three.
it's not actually
So
it does not actually cause a harmful effect, but if the patient has an anti-inflammatory process going on like rheumatism, and then the patient take aspirin, which is for moderate to mild pain, and you give the patient methotrexate, it will increase the effectiveness of the methotrexate. The aspirin goes to serve as a booster to make it more effective. So instead of just feeling a mild relief, the relief you feel might be stronger than only the aspirin. Okay. So the last question that aspirin is, what is methotrexate used for? I just said that. It's a chemotherapy
yes,
medication.
the
It's a
first floor
cancer
has
medication
a small 3-bedroom. You know, it's really nice 3-bedroom.
used for rheumatoid arthritis, rheumatic medications.
Okay.
Okay.
All right.
Okay.
We're trying to figure out if the
Thank
money,
you.
the cash flow is good for them.
Okay. So I see Simone is back.
Okay. Okay.
Can you see my screen?
Yeah.
How do you feel? That means you are not alone, right?
Yes.
We are all not alone in this. So people have been through it, or they'll come and be through it, they'll pass through it. So it's just a motivational quote. You've not come this far to quit. Others did it, regardless of stumbling blocks. There will never be a journey without a stumbling block. So the journey of Hercules is like a marathon, but relax your mind, don't go crazy about it. So we are going, I was saying that okay, Clementina just joined. I'm going to share the screen for today, and we're going to continue from where we stopped the last time. Then we'll go and review some stuff. Simon, were you able to read the document I sent in Google Classroom?
No. The only thing I got was the questions.
I saw that. It's just that I couldn't review it. I saw that you have submitted it, but I couldn't review it. The purpose for the question is not for you to just go answering, because at the point when you answer so many NCLEX questions, you kind of look at every question to be like familiar. It's like, I have already seen this question somewhere, I've come across it. But the purpose of that is for you to look into the topics and how the questions are framed. I was talking about some of the words that we use to confuse you in the NCLEX. There are certain words that they will use that will kind of throw you off. Like if they want to say assessment, they want to talk about, they tell you what are the interventions the nurse will do. And then they start talking about What instructions will you give to the patient? What teaching will you give to the patient? It all adds up to education. It all adds up to you giving the information to the patient. So when they ask of intervention, intervention is what you, the nurse, will do for the patient. It's not what the patient is going to do for themselves. So the NCLEX will bring a question and they want to know the immediate intervention. Immediate intervention, you put yourself like, okay, so they want me to do something right now. So which one is going to be the most urgent and the most needing intervention for me to do? So today we are going to go. Clementina, were you able to review the Google Classroom documents? I can't hear you. You are muted. You are muted.
I got it late, so I was not able to do that.
But you were able to get into the classroom?
Yes, yes.
Okay.
I will do the questions later today. But the document you're
It's
talking
due
about
on
is
Sunday. The questions are due on Sunday. I'm still having a challenge reading what they submitted. I don't know how the thing set up to give color codes. Simo, when you submitted, did you return a color code to you?
No.
You didn't get the color codes. I was
No.
trying to open your document, but I couldn't open it.
But you know what it did to me? I
Mhm.
got the 70 plus questions twice. It was repeated.
It was repeated?
Yeah.
Okay, I'll check that. I thought the Google Classroom was more mobile, like it's user friendly. Everywhere you are, you can always open it, even on your phone. So it's pretty much like a quick way to study, even if you are not ready. That's why I also put some materials on it. And you say you have not been able to review. I put some materials to read. I didn't want to load you guys with too much information because I know you are studying other stuff. So I put in some short notes for you to review. And I have a lot of them. I had mentioned that I'll be posting them like every week or so. I put like 2 or 3 pages there. You say you have not been able to see that one?
I haven't seen it yet. I'm gonna have to- Okay.
Okay. So the last time we were able to review the GI system. Are we able to see my screen right now?
yes.
Okay. So all these ones, I know we had reviewed them. I just wanted to go and read. I'm gonna go straight to talk about the disease conditions. I'm gonna run quick, and then from there we're gonna go to the pediatric one. Then we'll review the short notes that the questions I was asking the last time. So today we are going to start with paracentesis abdominis.
Please, before we start, I have a question.
Mhm.
I want to understand something. When you are asked, when you are asked in an exam, nursing intervention, does that include doctor's orders or something that the nurse will do before using the doctor's orders? For example, if somebody comes in with shortness of breath, for example, you have to raise up the head of the bed. Is that only what nursing intervention is, or does it include the doctor's order that the nurse have to implement as well?
Yes. To some extent, it depends on what kind of interventions that you are putting up. So if the patient coming with shortness of breath, you have to intervene right away before the doctor come in to give orders. So if the doctor order that elevates the patient head, keep the head of the patient bed up to so and so angle, you understand? That's where you are putting in your intervention based on the doctor's order. But in your nursing judgment, in the world of NCLEX, there is no doctor giving you the order yet. Even if the doctor is giving you the order, you assume you are doing this all by yourself. You have to think of what to do for the patient. So they assume that you have to know what is going on with the patient. So the patient has shortness of breath, and the complaint is you see the patient holding the chest, you see the facial droop and all those things. As a nurse or as an LPN, you already need to think what could be the problem. So if the patient is probably having a stroke, what should I do right now before the doctor come in? So your nursing interventions are always independent on what you, the nurse, should do. So if you miss a step, it can kill the patient. If you don't act on time, your action or your delay in intervention can be a detrimental effect. And NCLEX will always trick you to know which intervention will the nurse take first. That means the nurse is going to take all those answer options. You are going to do them. Questions that ask you, which intervention will you do first, or which one is the priority nursing action? Those are interventions. They are interventional questions that they are just twisting your mind to see what you will do first. So you want to think. If you don't know, that's one thing that make me feel like, or one thing that make me understand that NCLEX take you back to nursing content, but they put it in the practical world. So they take the whole nursing content and they put it in the practical world, that a patient presents to the emergency holding on to the right side of the abdomen, and the patient has projectile vomiting. When you touch, you could feel tender and blah, 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 blah. Which is the first thing you should do? It has taken you back to content, but they are looking for an intervention from that content. You understand? So if you are a nurse who already don't know the symptoms they are describing, forget of what to do. Do you understand? So the interventions are in different ways. Mostly in the world of NCLEX, it's you alone intervening. You don't use doctor's orders. But if the question bring up that the doctor has ordered so, and they want to know which one will you pick as the wrong one, then you should know. They expect that that particular disease condition they put in that question. If you know what it is, you will know which one the doctor is supposed to give. They are not going to take you into serious medical terms where you need a doctor intervention. So all the questions on NCLEX and the LPN, RN and the LPN are based on the knowledge and content level of the nursing aspects. So that's why they are not going to ask you to prescribe. They can only ask you to teach the patients. Okay? So the priority questions, try to pick up those that are more safe steps.
Those are the questions that I dislike the most.
Yeah.
There are those you dislike?
Yeah, because the answer options, everything will be correct. All
Yeah.
the four options will be correct.
That
Now
is that
which one to eliminate.
exactly.
So in that case, you try to look for the one that will direct you to providing a safe care. Clementina.
Yeah.
Let me ask you a question. A patient walk into the emergency department and complain of chest pain. What is the first action the nurse should take?
EKG.
EKG. Do you know that to some extent, is the doctor who orders EKG in NCLEX? It's not a nurse who orders EKG. You know why I asked you that?
Oh.
That's a straight clinical question. That's what the facility does. Okay? So you go to another facility, it's doctors who order. So the patient has chest pain, the nurse doesn't order EKG. First step.
No, but you know what?
Patients,
I work in emergency sometimes, and there's a lot of patients that come in with chest pain.
Yeah.
But we already know once they come in with chest pain, we just go right ahead and do the EKG.
Yes.
The doctor will see that the EKG is done because the patient is having chest pain. So he wants to see whatever is happening. After we do the EKG, that's when he put in the order. But we know that it's an order, it's something that the doctor has to put in.
Yes.
But because it is something that is an emergency, it could be anything. We have to go ahead and do it.
Yes.
But that
it's not,
could be a tricky question though.
but in the world of NCLEX, that's why I brought that one, because I know it's easy one that everybody can miss it. In the world of NCLEX, you don't order EKG. If the patient tells you, I have a chest pain, what time did the chest pain start? You rate the pain. That's what the nurse would do. That's nursing assessment. You want to know, you want to look at the patient's physical appearance. You want to know the time. If the pain started 1 hour and you see the patient already holding the chest and struggling to breathe, you rush the patient. EKG ordering is out of the NCLEX world. If they ever put that question, that answer in an answer options, that's not what you, the nurse, should do first thing. You see that happen, it's not happening in the NCLEX world. So there are other facilities that you also go. If the patient has a chest pain, the nurse is supposed to assess the vital signs first thing, and then you let the doctor know. The doctor will put the order in. So in the NCLEX world, don't ever pick an answer option. That will mean like the nurse have jumped from nursing to ordering. That's wrong. So if you pick EKG that you see it's being done every day, you will be wrong. You will not get it on NCLEX. So that's why sometimes it is difficult to blend the practical world, especially if you are working and you see things like that happen. So I want you guys to erase your mind from everything you see at the facility, okay? Apart from the patients that you see, they present signs and symptoms. Sometimes you even see the care being provided doesn't follow the steps NCLEX want it to follow. So I want you to erase your mind from that. Just make sure that you know the signs and symptoms of stroke when a patient presents for NCLEX. So the signs and symptoms of stroke will be facial droop, you understand, facial droop, slurred speech, and all those things. So when you see all that, then you are worried about ABC. The patient breathing normal. Don't
Okay.
on the floor, because that will make you fail. You go and sit on the NCLEX, and if you want to do it, because you see that the patient come in and they are saying STEMI, and everybody is rushing and they are rushing this to send the patient to MRI. Yes, the patient is supposed to be sent to MRI within a time period of 3 hours. You understand? But in the world of NCLEX, the steps they are going to follow to take the patient to the cath lab is different. The steps are different. So don't follow that one. Okay?
I learned that too, because I was studying with UWorld and I got a blood sugar question. I normally, as techs, we would actually, if the patient's blood sugar is low, we would just go get some orange juice or whatever.
Yes.
I answered that question wrong based on my
start with orange juice. You start with candy. So that's one thing I'm going to tell you. To let you know about NCLEX, the people that set the NCLEX questions, they are not innocent. They are not stupid. There are people like me who have been on the floor. And if I want to set a questions, I will use what is more practical. They set the NCLEX questions based on nurses who have passed the NCLEX in the last few years. And then they send those nurses an evaluation. I'm sorry to use this paper. They send an evaluation for the nurses to fill out. You understand, your first week or your first month on the floor, what did you see? What happened? And they answer those questions. So when they receive that as a survey, they use that to set the NCLEX questions. So there are questions that they really know happens at the practical world. But those are not the right steps that will happen at the practical world. Then they gather that and they use that to frame the questions. That's why the questions are so real. Okay? That's why the questions are so real. So a patient walk in and you see the patient right now and the patient is stable. In the next 30 minutes, the patient, I have asked this question before. I gave it to Freddie one time. Freddie got it correct. I was given a scenario of a patient I had, and the patient had patient walk-in complaining of an abscess, rectal abscess that started 3 days ago. And today the pain is so much that the patient came to the emergency. The patient is a diabetic. The finger stick 217. And so finger stick 217, blood pressure 124/90, heart rate 85, respiration 16, temperature 98.5. The patient had rectal incision and drainage from the site. So, but the patient has a history of diabetes, well controlled. That's what I'll put in that question. So history of diabetes, well controlled, patient coming. I have mentioned the vitals. I don't know if you guys were taking notice of those vitals, but everything looks normal with the vital signs except the blood glucose. Clementina, you can turn on your camera. I know I heard you say blood glucose.
I said, apart from the blood glucose, everything is normal.
Yes,
Yeah.
but you see that in the emergency, if the patient is already a diabetic and the sugar is 200 and something, and the patient is asymptomatic, they're not worried. But NCLEX is worried. You understand? So all these vital signs, this is the one that has the problem. But listen to the story. It's interesting. 30 minutes after the incision and drainage, the patient, you walk back in as the nurse went back to reassess the patient. You realize the finger stick is 201, 201. Blood pressure is 99/64. Are you taking notice?
Wow.
The heart rate went up to 124. Temperature is now 99.5. It was 98.5. Now it's 99.5. Respiration is still 16. What will you think about? What's your first thinking?
Hypovolemia.
Sugar came down. They already told you that sugar was well controlled. So probably the patient coming, the complaint is not about sugar. So just kick diabetes off the mind. It's a distractor in that question. So if they give you a question like that, that's a distractor, just to distract what you are thinking. So now the vital signs, it was normal on the first set. But after the incision and drainage, now you walk back, you reassess, and this is what you see. Only the sugar that seemed to be in the right side and the respiration seemed to be on the right side. The rest are going off balance. What will you think?
I'm thinking hypovolemia, fluid loss. That's what I'm thinking now.
Fluid loss. But remember, it's an abscess in the rectum that they cannot use
Yes,
it.
he's losing fluid from them, maybe so much.
Okay.
The abscess is draining fast.
Okay. Okay. Simone,
I
do
would
you?
think that the problem would be something something having to do with his vital signs, is saying more. I wouldn't focus too much on the blood sugar, since there was nothing major about that. But when it comes to the temperature, he has a low grade temperature. That's huge. Like, you come in normal and then maybe I'm thinking it could be an infection. There could be an infection somewhere.
Yes. So how will you relate all that vitals with infection?
No,
Let me give you a hint. Let me give you a hint. Think sepsis. You brought the word infection. That's all I was looking for. How will you relate these vital signs to sepsis?
The temperature rise.
The temperature is 99.5. Remember, it's still not a fever. It has
No,
only
a
increased,
low
but
grade.
there's still no
I
fever there.
think it's the hypotension that is setting it.
Okay, now, okay, that's good. So right now, the patient's blood pressure is coming down, hypovolemia, like you said, you will suspect. The heart rate is jumping high. Before, the blood pressure was 124/80 something, and the heart rate was 85, let's assume. So right now, the blood pressure was higher than the heart rate. Right now, the heart rate is 124, and the blood pressure has reduced. It has reversed the equation. That's sepsis. You want to suspect sepsis. Okay? So for a patient with alternating vital signs, like heart rate is going down, blood pressure is coming down, when it was not like that, and the patient has an abscess going on, and there's now low grade, it's like will I say one, because 98.5 to 99.5 is like one increase. So you look at that increase, and then you look at the reversing of the heart rate and the blood pressure. One was high and one was the lower side. Right now, one went higher, the other one came down. They have reversed equation. That's to suspect sepsis. So the initial thing you, the nurse, will do right now is, after incision and drainage, you see this one, these vital signs are not normal. You want to suspect that the patient might be septic, because there's no problem with sugar. The sugar was just a distraction. So in that question, you kick everything about the glucose off. When the second vitals come and glucose is normal, or even the second part of it, they don't mention anything about the sugar. You are not worried about the sugar because they said well controlled. Even if it's not well controlled and the patient is not showing symptoms of hypoglycemia in the vital signs or in the complaint, they didn't add anything about hyperglycemic symptoms to the question. And you see another portion of it talking about vital signs and sepsis. You focus on that. So sometimes they bring different topics and put it inside the question just to confuse you. Focus on the one that has most of the information related to the ending part of the question. So for a patient like this, you want to suspect that the patient might be septic. And if the patient is septic, what will you do first? Because now you have gotten vital signs, you have assessed already. You understand? So what will you do first?
Start giving fluids.
Yes, you give fluids. But remember the patient had a procedure, incision and drainage, and the provider left. So you want to notify the provider. You get an order for blood cultures.
Cultures. Okay.
Yes. So
I was going to ask because we had a similar question like that in my exam. So in a situation of sepsis,
did I send you that question, Clementina?
no.
I framed that question. I sent it to Freddie. I set it up into 3 different questions from that scenario. This was a patient I had.
Okay. So, but this issue now about what will a nurse do if a patient presents first? What will a nurse do first?
The answer options I gave to that question, I don't know why I put that question. I would have brought it out, but I'll look for it and then I'll post it up one of the days. I'll look for that question. I set it up with 3 different questions. Like I changed it into 3 different questions. So right. From it depends on what the question is now directing you to do. So if they ask you which one will be the first or initial nursing priority actions and they put the answer options that they are going to put on will direct you as to what to do. And the one that I put was, the answer was supposed to be to call the provider first. You understand? I'm going to look for that question. So let's leave it aside. But just to let you know, NCLEX is an entry-level test. It tests you, NCLEX or HESI, right? It tests you based on a certain level. It doesn't take you to be of an expert to understand what is going on. But it doesn't also take you to be an innocent student in school who still don't understand signs and symptoms. So they expect you to have a certain body of knowledge when you step up the floor. The first day you'll be a safe nurse to work with. Okay?
All right.
Yeah, so I'm going to get that question and then we clarify our thinking on that so that you understand. So the clinical world, just assume that I don't see it. Let's go by what NCLEX is directing us. Let's know the conditions, and when you see the question, you'll be able to figure out. So sometimes be mindful of distractors. Now, the other day we're talking about, I stopped at the common diagnostic procedures that we do with GI symptoms. Can we read my screen?
Yeah.
Yeah.
So you can read it.
We passed there already. So today I'm just going to get this one quick for you. Paracentesis abdominis, when they do the abdominal tapping. I'm going to go over it quick. Thank God today I've been able to edit my work so that I can share the screen. So paracentesis is removal of fluid from abdominal cavity. What's the name? Clementina, what you talked about the hypovolemia. So when you hear removal of fluid, that will be the initial complication I will start thinking about. So the first thing is that the nurse, this is just like the procedure. So I'm going to jump this aspect and I'm going to read here. So the nurse is supposed to ensure that you confirm that the patient has a consent form signed. I had an incident yesterday where a provider brought blood, was rushing a nurse to give blood right now, shouting and shouting, and the nurse is rushing to give the blood and they not verify consent. I walked in at that time. So I'm like, did you check consent? Nurse is like, I didn't. I said, no, I'm not doing this. I want to see it. So we had to see consent. So the nurse is supposed to verify consent for procedure like paracentesis abdominis because it's an invasive procedure. They are going to invade into the patient. So now it doesn't matter if you are LPN and you are the nurse assigned to this patient and they are going to do this procedure. They may not let you verify the consent, but if they will let you verify the consent based on the facility you work at, then you are supposed to confirm the consent and you notify your charge or the nurse that is where you are working with. So you want to make sure that you are the one in charge of this and you are not giving that patient care to another nurse. So if it's an LPN, they're going to question what you will know first. You want to know that there's a consent for the patient, okay? So you want to get vital signs and you have the client void. You want the patient to PP2 to empty the bladder. You position the client upright. So that's the positioning. So you want to position the client like this. You're going to see the stomach already protruded and all those things. Most of the time, there are patients with big stomachs that they want to tap the fluid from. So you assist the healthcare provider, you monitor vital signs and provide comfort and support during the procedure. So you're just going to hang around to be an assistant for the procedure. Yes.
Say upright, is it sitting upright or I don't know?
Usually if on that procedure, if the patient is on a stretcher, you can raise the stretcher up because remember fluid is coming out. So you don't want that patient flat. So if it's on a recliner chair, you have to recline the chair. And mind you, procedures like this cannot be done on a chair that cannot also flex. Cannot be done on a bed that you cannot position the patient well. So positioning upright can be making the patient sit upright or to just raise the head to a certain angle. That will keep the patient propped up. Yeah.
So
okay.
Yeah.
Yeah. So just remember the positioning for the abdominal tapping is upright position. And remember, you need consent verified. Monitor vital signs, measure amount of fluid removed. Now, this is input and output. The NCLEX always give questions under input and output for you to calculate. So they tell you a patient was in so and so, the patient takes fluid by GT tube and the patient is at a fluid restriction of this dosage, this amount. And at the end of 8-hour shift, how much fluid will you calculate? So sometimes if they want to know how much fluid you've given the patient or how much fluid you have drained from the patient, they will separate the input and the output. Other times they just want to get the total input and the total output for the patient. And they want you to be able to determine that is it too much or too less. So take note of this. We also have outputs recorded in paracentesis. Now the next one I'm going to move is gastritis. So the documentation of the event is the last thing. Every procedure you take in nursing, you have to always document. So documentation is another step you can never miss. Gastritis is inflammation of the stomach mucosa lining. So anytime you hear titis, it's inflammation. Anything that is titis is inflammation. So we have the acute and the chronic one. So acute one can be like, you know, when you have like upset stomach, when you eat something that your stomach wouldn't take it, you start having discomfort. So people who use NSAIDs and aspirin can cause that too. And mostly you should not take NSAIDs and aspirin at the same time. They don't work together. They have a bleeding effect. So you can also have foods that are infected with microbacteria.
Hold on, patients. One question. You said also by the H. pylori. Would that be under the chronic reason?
That's under chronic.
Okay.
Yeah, H. pylori, autoimmune disease is under chronic. Now, autoimmune disease can be lupus.
Yeah.
Do we know what lupus is?
Yeah.
Yes. So lupus is an autoimmune infection. It affects other body parts. Its complication is you start having other body organs affected by having like failure. You can have liver affected, kidney affected. Sometimes you end up seeing those patients on dialysis. You see them on other procedures that are different from that. So sometimes, and you can have cardiac symptoms too. They get like inflammatory cardiomegaly, inflammatory process of the heart and the lungs and everything. So autoimmune diseases, those causes chronic. Okay. So you see a patient saying, I have a history of gastritis. That's a chronic one. It's different from me and you who will just eat something today and then your stomach start acting up. You feel the discomfort for today and tomorrow and you are fine. Now let's look at the acute symptoms. You have the abdominal discomfort, anorexia, vomiting, and nausea, headache, hiccoughing, and acid reflux. Mostly, like I was telling you the other day, most of the abdominal symptoms will have, abdominal problems will have the same symptoms. So NCLEX is not going to ask you for, they're not going to focus too much on shortness of breath unless they want to confuse you with a disease process that has to do with the upper GI tract that will cause shortness of breath, or that will put pressure on the organs, internal organs, the heart or the chest wall organs. That was why I showed you the picture the other day of the abdominal structures and how they are lined up. I don't know if you can have that picture in mind, but we'll get to know what that is. So chronic, the chronic one will have the same thing. You're not going to have chronic and you'll be comfortable. You'll still be discomfortable. You'll still be uncomfortable. So even though they didn't mention abdominal discomfort, but remember, you can have it. It's a symptom. You will have that one. You'll be belching and belching. So you have seen, I don't know if any of you have seen people that keep belching it now non-stop. I had one of my grandfathers was like that. Anytime he's coming to the house, we're like, oh boy. We used to call him Mr. Fish. Mr. Fish is coming. He come and sit and he's like, ew, every few minutes, ew. It's disgusting, but it's an abnormality. So the patient will also have heartburn, sour taste in the mouth, and vitamin B deficiency. So remember the other day I was talking about vitamins in abdominal disorders. So vitamin B deficiency. So client teaching, you want to avoid irritating food and spicy stuff. Acute gastritis, the food maybe, you want to tell the patient to hold the food until the symptoms subside, okay? So you want to tell the patient not to eat right now. When you start vomiting or when you start having that discomfort, you feel nauseous, you want to stop eating. Sometimes nobody will tell you to do that. You yourself will learn that I'm not able to eat. So you want to hold on until the symptoms subside. And you monitor for hemorrhagic gastritis, symptoms such as vomiting blood, tachycardia, hypotension, and notify the provider as soon as possible. So abdominal discomfort can cause you to have tachycardia and palpitations. It can drop your blood pressure because of the...
You could also become Brady as well.
Brady, yes. It goes back and forth. Depends on, especially if you have vomited so much, everything, you go tachy and your blood pressure goes low. So you can become hypovolemic through that. Okay. Now, gastroesophageal reflux disease, that's GERD. So it's the backflow of gastric contents, gastric and duodenal content into the esophagus. I don't know if you want to see the picture that I created the last time, but it will give you a clear link. You may not need to read it again. You just need to memorize it. Do you want to see the picture? The backflow of,
Yes.
Okay. So the backflow of gastric and duodenal content back into the esophagus, which is more like closer to the heart, to the mouth. Are we reading the other portion? So that when I come out, jump. I'm coming. Okay. Okay. So backflow of gastric content whatever is in here. You understand? So from the duodenum, this is the duodenum, which starts the beginning of the large intestine. So when the food starts backflowing from here to here and to the esophagus. You understand? That's why you start having this serious heartburns and you are just not comfortable. You start feeling like the pain is in your chest. So the patient is going to point the discomfort to the chest because you see the location of the esophagus. The patient will point the pain to the chest. I have back chest pain, but I feel a little discomfort to down here. So it moved down here to this. So the patient is going to describe the pain starts from here and it moved down to this, to my chest. So there's pressure on my chest. So if you're not careful, you'll be worried about, that's why sometimes patients complain of stomach pains and you see them do an EKG. You want to make sure the upper chest wall structures are all intact. So that's what I wanted to explain. Let's go back to where we were before. Now I can't find my document. Okay. Okay. So the symptoms will be heartburn, epigastric pain, dyspepsia, nausea and regurgitation, pain and difficulty swallowing, hypersalivation. So if you give me hypersalivation, I'll consider it as nausea too. Client teaching, you want to tell the patient to eat low-fat diet because low-fat diet will not digest early. You want the patient to also avoid peppermint food, chocolates, coffee, fried foods, carbonated beverages, and smoking. All those things aggravate the stomach. So anytime they are talking about abdominal questions in the NCLEX, and they mention smoke, they mention coffee, I don't care what condition it is, but so far as it's on the GI, I'm kicking that answer off. If you're looking for a negative item to select, I will try to understand the context they put the coffee in, how much or which scenario is the coffee being placed, because it will always be wrong. Okay, I see so many people take soda, ginger ale for stomach discomfort, especially my fellow Africans. We think ginger ale help reduce stomach stuff and blah, 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 blah. Sometimes you see people vomiting, they're taking ginger ale, but NCLEX world, it doesn't happen. We consider that as home remedy style. Don't take it on NCLEX. So you want to encourage the patient to eat low-fat diets and high-fiber diets. High-fiber diet will help bring the food down. It will help in digestion. It wouldn't digest too fast and it wouldn't digest too slow. So you want to encourage the patient to eat that one instead of the high-fat diet. And then also avoid wearing tight clothing. And you know, sometimes we ladies, especially if my stomach is too big and I want to press it down, I've actually been a victim of that. Put on some corset and I went to church. I had to go take it off because I couldn't breathe. I just felt like I was killing myself. So I started thinking, I'm like, are my intestines okay before it start cutting off inside? So we want to avoid that if you have that problem. So you also want to let the patient know when they sleep, they should use a pillow at least to elevate their head so that the food will not be backing up and coming up. So this one is to support gravity. So if your head is a little elevated, food will not go up. Now, peptic ulcer. So we have two types of ulcer. We have gastric and duodenal ulcer. So ulcer is the ulceration or like a sore being formed around the mucosal lining. It could be in the stomach, the pylorus, the duodenum, or the esophagus. And this one inhibits secretion of abdominal amylase, like the gastric enzymes. It will inhibit secretion of it. Where am I? So the common types I said are duodenal and gastric ulcer, and it depends on the location. So it's more, if it's a structure that is around the duodenum, And we know the duodenum is the beginning portion of large intestine. So if the ulcer is around that side, I'm worried I have to call it duodenal ulcer. And if the ulcer is more to the stomach, closer to the esophagus, I will call it gastric because it's in the stomach. So the risk factors or the causes of it will be steroid, too much steroid. When you use too much cortisone, I don't know who is in the waiting room, but I'm gonna admit somebody. Okay, so we have steroid, NSAIDs, alcohol. Like I said already, anything alcohol, anything smoking, try to be on the safer side. If they're looking for negative behaviors in the NCLEX, you try to look for things like this: alcohol, NSAIDs, things that will irritate the GI system. So you want to try to look for those things to avoid any GI bleed, because gastritis, peptic means there's already a wound. So if you keep taking NSAIDs on top of this, keep drinking alcohol, Helicobacter infection can also lead. It's a risk factor. Signs and symptoms of gastric ulcer. So we'll have gnawing pain, we'll have sharp pain to left mid epigastric region. So looking at this side we are discussing, the ways NCLEX will present a question to you is that a patient or a nurse caring for a patient with a history of gastritis. They are going to just either mention the name. A nurse is caring for a patient with a history of, they will describe the location of the ulcer. They are not going to tell you a patient having an ulcer closer to the duodenum. You understand? And ulcer closer to the duodenum. The patient tells you that anytime I eat food, it doesn't start away, but the pain starts like about 1 hour time, or the pain just starts like within 30 minutes or within 45 minutes, I start feeling the pain. And then they give you the answer options. In that question, they are directing you straight. You need to know what gastric ulcer is. And then they give you another scenario of a patient that you are caring for, or a patient that comes to you, gives you a complaint and tells you the pain starts 1.5 to 2 hours time, or 3 hours time after eating. Or when I'm sleeping, that pain wakes me up. It's duodenum. Remember, when the food goes to the stomach, it takes time to get to the large intestines because it has to get grinded inside the stomach before it starts moving. So the timing for onset of pain in the gastric is 30 to 60 minutes. It's shorter because it's right in the stomach. So the moment the food drops down your stomach, 30 minutes, your stomach starts sensing that something is not right. There's an ulceration, and the ulcer, the secretions of the body, the enzymes, it starts chopping on, it tries to chop on the food, but it's irritating the wound area. So in that case, you start feeling the pain fast. So I know a lot of students, because me myself, I used to get confused about that timing. So anything that is gastric ulcer, if NCLEX is describing the pain and says it starts within 30 minutes after eating, or 1 hour after eating, between 30 and 1 hour. So they can give you 35 minutes, 45 minutes, 50 minutes. The patient can tell you that. Go straight to gastric. Don't look for duodenal, because duodenal, it has to digest in the stomach. That means the stomach doesn't have any ulcer. There's no wound in the stomach. So the stomach takes its time to blend the food. And after blending the food, it comes down to the duodenum. That's when you start feeling the pain. So the duodenal ulcer, it takes up to 1.5 to 3 hours for the pain to start, or it will wake you up in the night when you are sleeping. When you finish eating your dinner, you are asleep, it takes time to wake you, because that means digestion has now gotten there. The next one is signs and symptoms, surgical intervention. So most of these ones will have a surgical intervention. Most of these ulcer stuff, they do give it a surgical intervention, and the surgical intervention can be total gastrectomy. If it's too much, they'll just remove the whole stomach. If it's not too much, then they try to cut portions of it. So when they try to cut portions, it can be partial removal of the stomach. So they remove part of the stomach, and then the anastomosis, they pull the stomach to the duodenum. So if they are cutting the lower part of the stomach, they pull it to the duodenum and then they connect to it. And if they are cutting the duodenal part of it, they pull it down to the jejunum. That's why we have gastrojejunoscopy and BROF 1 and BROF 2. So it depends on what they are pulling to connect to what. Then you'll be worried about it. The ulcer in the mucosa of this one is the duodenal ulcer. I think I explained both of them together, right? Can I go? I can't hear you.
Yes, go ahead.
Yeah. Simone, are you hearing me?
Yeah.
Okay, signs and symptoms. I already mentioned all these ones. Now the client teaching, you want to teach them to try to avoid sugar, milk. So these teachings you are going to do is what NCLEX will set the questions on. So they tell you that the nurse tells or the patient is going home and the patient has been diagnosed as having duodenal ulcer. What teachings will the nurse provide, or what are the teachings the nurse should give to the patient? And you have this option there. It might be too easy for you because you look at it straightforward, but they'll put a word in the question just to confuse you. So these are
One question I saw was say avoid peppermint.
You say?
So there was a question that says you should avoid peppermint or something like that.
Was that a correct answer?
Yeah.
Yes. So anything that will cause
avoid-
irritation.
To avoid what? I didn't hear that.
Peppermint.
Peppermint.
Yeah.
Remember when I was talking about gastritis, I spoke about peppermints.
Okay.
Yeah. So he's saying that there was a question like that, and another answer option said avoid peppermint. So these are the two things. That's why I limited my presentation on those things. The signs and symptoms are what NCLEX will look out for. They want to know if the nurse is able to identify those things, and they want to know if you are able to teach the clients. So you should be able to know how to teach, and then signs that you use to identify. Now, if they tell you assessment findings are the same as signs and symptoms. So if you see it as what assessment findings will the nurse get? So your assessment findings will be the same thing as the signs and symptoms, okay? Now, the difference will be subjective and objective if we remember our nursing process. So the assessment findings, they want you to assess the patient and find it. So when you assess, you see the vital signs, you see palpitations, and you see the tachycardia, you see the patient heart rate elevated. That's your assessment findings. Do we understand? And then you see that nausea, vomiting, you basically see that. That will be assessment findings. And then if the patient tells you, I have this starting from this time, that will be objective. The patient objectively tells you that I have 30 pain that starts in 45 minutes after I eat the food. So that directs you straight. So note the client teachings for all the disease conditions. I tell you, you cannot know all. Just have an idea. Like I said, GI, we know that everything about nausea, vomiting will be there. Everything that is not good for the stomach, I will apply it to all of the GI disease conditions. So on the NCLEX, when you see GI questions, know what to teach the client about. Mostly it will be diets, because it is food we eat that goes into our stomach. Mostly it's the food that will give us problems. Now, vitamin B deficiency is inadequate vitamin B or lack of absorption of vitamin B in the intestinal tract. Now, the signs that you see that the patient will be pale, will present with feeling tired, be losing weight. We have intentional weight loss and unintentional weight loss. Some disease conditions will present with you with unintentional weight loss. Slight jaundice. You see the patient slightly yellowish, not too much, because it's not yet liver involvement. So it will be a little bit. Paresthesia of hands and feet, unable to hold it, unsteady gait and balance. You see the patient not balanced. That tells you something is not right. Then the client teaching for vitamin D vitamin B12 deficiency. You know, we have a lot of vitamins. So vitamin B12 is specific for GI tract function. So that's why they are bringing it, and it's on the upper side of the GI tract. Now, instruct the client to eat diet that are high in vitamin B12, citrus fruits, dry beans, green leafy, organ meat. Listen, food stuff like this, they have so many other nutrients. So if I am you, I'll take note of liver or organ meats. I take note of citrus, which has vitamin C. It has so many other nutrients in it. Green leafy vegetables, you will find different folic acid and all those vitamins in green leafy vegetables. So they will ask you questions that they want you to choose things that, so you need to know them by classes. So if it's dry grains or dry grains, you know that it has a lot of fiber in them. So pick them in classes, group all those things in groups so that you easily remember, because you cannot know everything offhand. Now, bariatric surgery, this is a surgery that they do for people that are morbidly obese, and it's to help them lose weight. Usually it's a surgical procedure. It can be a same-day procedure if the patient don't have other comorbidities or if there's no complication in the procedure. So mostly it goes by support groups. So you want to refer the patient to American Association of Bariatric Surgeries. They do those things, and then they'll get more information on that and how to try to maintain the weight, because they do that surgery to try to reduce abdominal fats. So if the patient is so big and cannot enter this door, they want to do the surgery to reduce the stomach, because all the fat is based around the stomach. So they do the surgery to reduce that fat in the stomach, and then they have the patient lose weight. So it usually goes with support groups. You want them to be able to talk to other people that are having the same problem, so that they don't feel left alone. They can get depressed. They don't feel left out alone. They have support from other people. Now, hiatal hernia. So we know that hernia is protrusion of organs into other stuff in the body. So if it's hiatal hernia, we have the hiatus around the diaphragm, just underneath, between the two breasts and closer to the abdomen, the lower abdomen. So if there's protrusion of abdominal organs in there, then we'll have hiatal hernia. So it protrudes between the thorax. We know the thorax is around here. So you see that place bumped up. I don't know who has ever seen this, but when you see that, you see it bumped up on the abdomen. Now, the signs and symptoms to look out for will be heartburns, regurgitation, or vomiting, dyspnea, and feeling full. So the patient will complain of feeling full, but some patients, you can visibly see the bumping around that area. Now, what do you teach the clients about? So you teach the client to eat small, frequent meals and limit fluid intake with meals. So this is another thing. They ask you to either teach, or they ask you what will the nurse tell the patient, or what will you instruct the patient about. So to instruct, to educate, and to inform the patient is all teaching. It's a teaching function in nursing. You can be an LPN, you can be an RN, you have a function to always teach the patient. Okay? So the difference is assessment. You don't assess the patient, especially with initial assessment. You can do follow-up and inform the nurse, but you have to always teach the patient, because you walk to the patient asks you a question. What am I taking? What is this? And you have to teach. So every little thing you tell the patient, even if you are a nursing assistant, you still teach patients. So teaching is a nursing function. LPN, RN, HESI student is a function you need to be able to play to put you to standard. Now we are going to cholecystitis. This is inflammation of the gallbladder, and it can be acute or chronic. So we have acute cholecystitis and chronic cholecystitis. So the acute one can be associated with gallstones. That's why they will do a surgical procedure called cholelithotomy. That's the cutting part into the gallbladder to remove gallstones. But the term they usually refer is cholelithiasis. So acute cholecystitis is gallstones in the gallbladder. Then chronic is as a result of ineffective emptying of bile or diseased gallbladder, which cause fibrotic hardening, contracted bladder. So when you have a diseased bile, you know, when I showed you the other picture where the bile is located inside the gallbladder or just closer to the pancreas, and it moves a line to the gallbladder. Let me see if I can share this one to you. Okay. So let's look at the position of the gallbladder. So this is the gallbladder, and this is the bile duct. So if this one is chronically ill, it's been sick for a while, it becomes hard. It becomes a little hardened, and emptying it, start emptying into the gallbladder. And this is not a normal findings.
So it's located at the upper right hand side of
You
the
say?
body.
Yes, it's more to the upper right side. You see the pancreas cut across both right and left. So a portion of the pancreas is on the left side. The tip of it is on the left side. And the other side is on the right side. The bigger portion of the pancreas is on the right side. But when you look at the gallbladder, it's on the right side. Okay? I don't know if we understand what I'm saying. But the liver,
Yeah, I do.
the position of the liver is more to the right side. That's why after liver procedure, you position the patient on the left side. Okay. So let's go back. Should we take a break? Look like we are tired, right?
Yes.
Okay. So let's take a 15-minute break. We don't have too much. I'm glad we don't have too much to cover so that we'll have some more time to finish up. So we'll take 10 minutes or 15 minutes. Which one?
15.
15 minutes. Okay, so we are taking a 15-minute break. Okay.
Thank you.
Simone, are you with us?
He's tired.
We are taking a 15-minute break. We are almost done with the GI problems, and then we'll come back and finish it up, and then we'll go and we'll do our quick exercise, and we are gone. Okay. Okay, so see you 15 minutes. Let me see what time. Yeah, so 7:35. We'll be back. Are we back?
Yeah, I'm here.
Okay, let's go quick. Who else is back? Okay. Okay, let's go quick so that we can do this exercise. So I was talking about cholecystitis, inflammation of the gallbladder, and polylithiasis, gallstones involved. Client teaching. Usually when a patient presents with the signs and symptoms, there will be right upper abdominal quadrant mass. So on the right hand side of the abdomen, on the upper part, there will be a mass. The mass will be identified when you put your hand to palpate. So after palpation, you realize that there's a mass on the right upper quadrant. There'll be nausea, vomiting, indigestion, belching, and flatulence. The patient will keep doing poo, poo, poo all over. Epigastric pain that radiates to the scapula 2 to 3 hours after eating fatty foods. So these are signs and symptoms. The NCLEX is going to tell you, they're not going to tell you to identify the signs right away because they want to trick you. They will tell you that the patient comes to tell you that I have right upper abdominal quadrant pain. So they're going to describe the location of the pain. So NCLEX will describe the location of the pain. And then they tell you the patient also said, so that means you are gathering information from the patient. So the patient also mentioned to you that the pain usually starts between 2 to 4 hours. Or the patient will say 3 hours after I have eaten, then I start feeling that pain. Or when I eat something that is fatty, when I eat something that is like, let me say, that has cheese in it, the patient can mention specific food. If I eat something that has cheese in it, I start feeling that pain. And then that pain kind of moves to like my shoulder. So I have the pain here, and then sometimes I feel another pain here. They may not tell you it radiates, but that's the term to always use. But if the patient don't say it radiates and they describe here and you can feel a mass there, and the patient also tell you, I have pain in my back shoulder, upper shoulder here, on the scapular region, or here, I feel there's a pain. It's not on my chest, but the pain is right here. Those are the descriptions NCLEX is going to want you to see. And they will tell you the pain can stay for up to 6 hours. Okay. Are we taking notes or we are just listening? I just don't want to be talking. I want to make sure we are getting it.
I screenshot everything.
Is there?
I do screenshots.
Yeah. I can forward the document to you. I want to make sure you guys, like, sometimes it's better you understand when the person is presenting, because if you go back to read all these things, it will be like a lot of work to do than just having it explained to you, picking up points, and it's giving you a clearer understanding. So the first thing you want to encourage is to have the patient NPO, because if you see the mass on the abdomen, you don't want the patient eat. You don't even know what has gone to fix inside there, and the pain is there. So you want to maintain NPO. So most of the abdominal assessment, when you assess a patient and you see the patient's stomach tender and firm, you can feel a rebound tenderness. If I am you, the best thing I would tell NCLEX is to have that patient not eat anything at the moment until after assessment. Okay, so until after assessment, you maintain NPO. You see the patient, there will be vomiting, there will be nausea. You give antispasmodic, analgesic. You encourage low-fat diet. Avoid gas-forming foods. We have some food that you eat and then you are just passing out. You are just passing out all around. So mostly it's surgical intervention, and they remove the gallbladder. And that procedure is the cholecystectomy. Anything that's a dectomy, there's a removal. Anytime there's ectomy, there's a creation of hole. Or ostomy. Ostomy is hole. So there will be incision into the duct to remove gallstones. So they put that, they go through the stomach, the abdomen, the right-hand side of the abdominal wall, and then they remove the gallstones. Sometimes they try to give the patient some medications that will help, but mostly that will be in kidney stones that they try to give the patient medications they'll give the patient like Flomax to help relieve the pain and have the patient drink a lot of fluid to pass the kidney stone. But in gallbladder stones, it's kind of hard to manage. Sometimes they try to give you anti-inflammatory medications to have you go home and take it. So it is not bad for you to see a doctor prescribe anti-inflammatory or an NSAID for a patient having this kind of pain, even though NSAIDs usually aggravate bleeding and all those things. But remember, if you have stones in your gallbladder, it can cause inflammation. So in that case, they can still order anti-inflammatory medications. Now, liver cirrhosis. So liver cirrhosis is progressive destruction of the liver. It's usually chronic. So before you see somebody's liver is destroyed, it's chronic. We don't have a temporary or acute liver cirrhosis. Where there's cirrhosis, that means it has been progressively, something has been progressively destroying the liver cells, and now it has become chronic. It's not reversible at that point. So portal hypertension is persistent increase in pressure in the portal veins as a result of backflow of blood. You know, when you look at the structures of the liver, I think I should have gotten a picture of that. When you look at the structures of the liver, you see the portal vein that carry blood from the heart to the liver, and then it takes it back. The artery takes it back. So when you have that blood flow that is persistently increasing in pressure, that means there's backflow of the blood. So instead of having the blood go in, it goes and coming back in the same line. So, and the pressure keep building. So once it's struggling, moving back and forth, another blood is coming, because the body is supposed to consistently run 24/7. So when I have the blood in here and that blood keeps shaking, it's trying to go, but it's facing resistance. So it's not moving. And this one is coming. So more is being pushed by the heart through the vein to go, but there is no space. So you see that there's stasis, stagnation in there. So when that happens, you see that there's a backflow, and that is a complication of liver cirrhosis, because that's where the liver now starts serving. You can't get more vitamins, oxygen. The liver cannot push and do its work right. Now you start seeing ascites. Because it's chronic, this is why you see it. It's happened progressively. It didn't just happen today. It could have been years. So ascites, you see the stomach like this. The person is not pregnant. That's the natural pregnancy. Natural pregnancy, you don't have to be a woman to be that pregnant. So you see ascites, you see the abdomen all big. You see jaundice, signs and symptoms. You see jaundice. So complication of liver cirrhosis are two complications. You are worried about portal hypertension and ascites. And the portal hypertension is when the portal vein is not able to freely allow blood to go in and out. And ascites is when there's accumulation of fluid in the abdominal cavity. And this can lead to abdominal tapping, the one we had seen first. What was the first topic I did? I forgot that one. The one we did, the abdominal tapping, the one that will remove the fluid from the abdomen. So you will see jaundice, vitamin deficiency, ascites, anorexia, abdominal pain, and several things. Liver function. Liver function affects multiple organs in the body. So this particular point, I was trying to let you know the signs and symptoms are not only these ones that I have written down. There are a bunch of them, 1,001, from head to toe. If the liver is not functioning, every other body organ is affected. Endocrine system is affected. Renal system is affected. It's already a digestive system disorder, so I'm not talking about it. Cardiovascular is affected. Remember, I just mentioned portal hypertension. So every symptom they can bring that you think will ever relate to abdomen will give you a sign and symptom of liver cirrhosis. And it's always, when you start seeing ascites, that means the person is near end, because that means body organs have been affected, or in the next few weeks, the patient's other body organs will be affected. It's not an autoimmune, it's just It's just a complication of liver cirrhosis. So you also see esophageal varices, dilation of the veins in the submucosa of the esophagus caused by portal hypertension, which is often due to liver cirrhosis. So the esophagus, like we saw that picture, you see the esophagus, the lining, every organ in the body has a thin lining that covers it, that protects it. So you see the lining being worn off, it will be chopped off gradually. And this one is as a result of the portal hypertension, when the portal vein is struggling to pull blood out. Now, signs and symptoms of esophageal varices is hematemesis, that's vomiting blood, melena, ascites, jaundice, hepatomegaly, splenomegaly, dilated abdominal veins, and signs of shock. So signs of esophageal varices, dilation of the esophagus, the mucosa of the esophagus will make the patient to be vomiting and vomiting and vomiting blood. There will be blood in the stool. Your stomach will be distended as well. Mind you, this has to do with the liver as well. Your spleen will be inflamed. You know the location of the esophagus down to the stomach, and then if there's portal hypertension, it goes straight to the gallbladder and the liver and all those structures closer to that. You know the gallbladder is all stuck up where the liver is. So that's where you start feeling the effect. Now let's talk about hepatitis. Hepatitis is the inflammation of the liver. Inflammation of the liver caused by virus, hepatotoxins, or exposure to certain medications. Goal for treatment in hepatitis is to rest the inflamed liver to reduce metabolic demands and increase blood supply, which promotes regeneration. Now, the types of hepatitis, I want to rush over that particular one, this area. So inflammation of the liver, just take note of that. It can be as a result of hepatotoxins. That's toxins in the hepatic region. That's around the liver area. Toxins that goes there and accumulate, it can destroy the liver. That will cause it. And then exposure to certain medications. Some medication, you know, the liver detoxify medications. NCLEX will always ask for that one too. So if medications get there and there's detoxification, the liver is not able to detoxify. You see that somebody will tell you if you take too much Tylenol, Tylenol can affect your liver. So some medications, too much of it, too much exposure of it can cause that. The types of hepatitis are A, B, C, D, E. Let's go. Now we have stages of hepatitis, stages of viral hepatitis. We have the pre-esoteric stage. That's the first stage of hepatitis. And this stage would go before the appearance of jaundice, which is like flu-like symptoms. So you start having signs like flu-like symptoms. I know we can all know what flu-like symptoms. You can have a fever, you feel tired, you feel weak. You just feel generalized weakness or feeling tired and weak. That's the signs of flu. You feel like you're having common colds, sneezing, and all those things. But sometimes you're not going to have cough. Specifically, there will not be cough, but you just feel like you're having flu. So, and the second stage is the esoteric phase. The second stage includes appearance of jaundice and associated symptoms such as elevated bilirubin, dark or tea-colored urine, and clay-colored stool. So you see your stool is clay. I don't know who has ever seen a clay-colored stool, but you always see that kind of stool in dogs. Dogs poop, you see it looking like clay. The color look a little gray. It's not pure white, but a little clay. So, and you can see it will either be dark urine or tea-colored urine. The urine will be very concentrated. It looks tea-colored. Elevated bilirubin will be done in blood work. So when they do the blood work, they'll see that bilirubin is high. That's where they start questioning. So that's the esoteric stage. So pre-esoteric stage, you just have mild flu symptoms. The second stage, you have development of jaundice. So if you have hepatitis, it's 3 phases your body goes through. Now the third stage will be post-esoteric. So post will mean after the development of jaundice and after the elevated bilirubin has been detected after T-colored clay stool and urine. The post-esoteric stage is convalescent stage of hepatitis, in which the jaundice decreases and the color of the urine and stool returns to normal. So at this stage, it's like the hepatitis or the virus have established itself well. So it makes your body goes back to normal. But mind you, it is not done with you. It's just kind of relaxed. And at that point, the lab assessment they will do will be ALT, which elevate when there's elevation above 1,000, you want to expect. So the ALT, let me get my record straight. Let me just check. I think that is done in CMP. When they do CMP, you know, like when we draw blood with the CBC, when we draw blood with the lavender tube, I don't know who has seen that.
Mhm.
When you do CBC, you have bilirubin there, you have ALT, AST, and all those chemicals in them.
So
Complete blood.
the CBC would cover all blood because it's complete blood count.
Yes. So CBC, when you do CBC, you have all these things here. And each of them has a range. So if the doctor look at hemoglobin is normal, the doctor look at creatinine is normal, the kidney is still working all right, nothing will be identified. But they see the ALT is over 1,000. Then they see the AST is over 1,000. The normal should be, this is the normal for NCLEX. Facilities will have different ranges, mind you. So if you work in a facility and you've been seeing all these labs, the facilities have their ranges. So what my facility will use as their range is not what Monty is going to use as their range. So just mind you, sometimes the difference might be plus or minus 1. That's facility. We are worried about NCLEX. So on the NCLEX, you're going to consider 10 to 40 units per liter as normal. So anything about ALT that is above 1,000 or even above 40 is not normal. But mostly in the case of hepatitis B, viral hepatitis, it's going to elevate up to the thousands. So that's what you are concerned about. Okay. So sometimes you can see an elevation of 50 and nobody's worried about it. It may clear. Sometimes some virus will just affect your liver and within some few days clears off. Nobody worried about it. But where it gets to 1,000 and plus, you are worried. Where the AST also gets over 1,000, you are worried. Ammonia should be 10 to 80 mic per deciliter. So where ammonia is elevated, you are worried because ammonia can cause encephalopathy. So because of that effect, when it's elevated, you are worried. If it's above 80 and sometimes if it's 90, you may now be worried, you may think it will clear up. If it's just ammonia that is abnormal out of this, you are not going to be rushing for it. You assume something didn't go right and it will clear off. But if the ammonia is over 250 and it's 500, you are concerned, that's an elevation. Total bilirubin and elevated in serum and urine. And the normal level should also be less than 1.5. When you do urine, when you run urine, you will see that we have that in there, and we also have that in CBC. So you see the bilirubin level, it should be less than 1.5. So if it's elevated, then that means something is wrong with the liver. Hepatitis A is infection.
Question. Under what circumstance would they use the urine to test the bilirubin levels? Because normally they would just do a CBC.
It's normally in the blood, but when you run blood, when you do urine analysis, they have all dimensions, but they don't focus on it. Mostly it's the blood they are concerned about. So with the urine, when you do UA, you see they are only concerned about urinary symptoms. And if there's any possible bleeding, that's when you are concerned. But bilirubin is mostly in the CBC. where you will see the levels elevated and you are worried. But mostly in the urine, they are just concerned about bleeding stuff and all those infections and viral infections, bacterial infections in the urine. Okay.
Okay, so follow up. All these elements that we're seeing now, this liver test, is it the liver function now or part of the CBC results?
I'm only telling you where you will go to find that. We have liver function tests that will be done.
That one is a different test. But this
That
one
one is a
not.
different test, yes.
But this
But-
result now is from CBC, right?
Yes, but in general, if the patient presents to you, you don't go to do liver function test straight because you are not already suspecting anything. So now that you have all these ones elevated, it sends you direct to a higher step of management. Now you are concerned that if AST, ALT, ammonia, and bilirubin are all off, or if 3 of them are off, 2 of them are off, I'm concerned something could be going on. That's why you follow up with a confirmatory test. So you do liver function test, which will specifically confirm that all those things you saw, something is actually wrong with the liver. So we don't order that initially. It's a follow-up test, just to tell you that your suspicion is right. Are we okay? Any question?
Yes, thank you.
Now we have hepatitis A. Hepatitis A is an infection that is mostly in the fall and early winter stages, and it's mostly in children, okay? So hepatitis A is a problem with children most often. That doesn't mean adults cannot get it, but it's usually seen in pediatrics. Transmission mode is fecal oral. This is what NCLEX will be more concerned about. Most of these hepatitis, they are concerned about the mode of transmission. So it's fecal oral, anus and mouth, hepatitis A. Contaminated food, getting in contact with a person who is infected with hepatitis A. Contaminated water and milk, poorly washed utensils. And mind you, all hepatitis B, the best way to overcome is hand washing. Hand washing for all hepatitis cases. It doesn't matter hepatitis 100, hand washing is the most safest thing to look out for in hepatitis on the NCLEX. So the incubation period for hepatitis A is 2 to 6 weeks. So if you get contacted it now, I'm not going to show any symptoms, but 2 weeks time is just like the COVID, they'll tell you from 3 to 5 days or whatever days. 3 to 5 days, you start manifesting symptoms. So if I got in contact with you and you have COVID, within 5 days I start. So the incubation period for that, for hepatitis A is 2 to 6 weeks. So it can take me up to 6 weeks before I start showing signs, before you start seeing me manifesting. And the manifestation will come in the pre-esoteric, is it esoteric, pre and post-esoteric. So those are the stages all viral hepatitis go through, okay? Then we have the infectious period is 2 to 6 weeks infectious, and 2 weeks before and after development of jaundice. So after, if I develop jaundice during the hepatitis and I even got healed, 2 to 3 weeks after that, I will still be infectious. Or before jaundice develop, in 2 to 3 weeks, that period I'll be infected, either before or after. Now, the safest action I already told you, hand washing, stool and needle precaution, treatment of municipal water bodies, vaccination. So we have a vaccine for hepatitis A. I forgot, adults have a vaccine for that. I forgot the name. I will tell you, I think I have it somewhere.
Patients. Can you go up a little bit more, please? I just wanted to look on the hepatitis.
This way?
Yeah.
Hepatitis A?
So even in hepatitis A, jaundice would be present.
You don't have to distract me. Melanie?
Hepatitis A
Mm-hmm.
in children,
Uh-huh.
they would still develop jaundice?
Yes,
Okay.
they will develop jaundice. It's more like in the end stage or like a complication. It can clear off without jaundice, But so
Right.
far as the liver is affected, mind you, I had read somewhere that it will be mild jaundice. There may be a mild jaundice. It will not be something like severe. And you remember, if you remember the treatment of jaundice, most often it will be phototherapy. So
Yeah.
NCLEX will also always want to know, patients having jaundice, treatment will most likely be phototherapy, light, exposure to direct light.
Babies, right, exactly.
Yeah, baby, like you said, is it only for baby? What about for like 5-year-olds? Is it possible with 5-year-olds?
Yes, children.
Yeah, they get
So how do
UV rays.
do you still treat with phototherapy in those ones?
Anybody that have jaundice, phototherapy is good for the person. But to some extent, in adults, they try to give other medications to clear off. Mind you, the phototherapy in newborns are as a result of the RH incompatibilities that causes that they are afraid it might move to the liver to affect the newborn's liver. So they make that phototherapy more intense. But in most cases of jaundice, phototherapy is recommended. Your exposure to sunlight gives you vitamin D, which help in the healing process for the liver to be able to clear off. So phototherapy is a good treatment, it's not only for newborns, but for children with hepatitis A is good. Okay. So if the mother tells you that, if in the NCLEX question they tell you the mother said, I will expose my 2-year-old to direct sunlight because the sun has jaundice, don't keep that answer off. It's fine. Okay.
Alright.
So
Yeah.
that means the mother understands jaundice and what should help. It may not be the real medication right now for that boy, but it's a helpful treatment to consider. Now we have
In a question like that, patients, let's say they would say, because we get a lot of those questions where it asks, what response would a parent do that would suggest they need more education?
yes.
So it's like how we could say that, okay, the mother could recognize that direct sunlight can help. What would be the opposite? Like, let's say in the same scenario, and the question would ask, what would suggest that the mother would need more education?
So it will suggest that the mother need more education. If the mother tells you, I'll keep the child in a dark room and I'll close all the curtains.
Okay.
Where there's prevention of light, you want to question, does she know what jaundice is? You understand? So jaundice is cutting across pediatrics now. So you want to make sure the mother understands. So even if it's a baby that is developing jaundice, you shouldn't put the child in a dark room.
Yeah.
You want it to be a well-lit room. Or if the mother tells you that, oh, my child's symptoms started 7 weeks. My child started having these symptoms, it started 7 weeks now, after he was in contact with somebody who 7 weeks ago said she was hepatitis. That means the woman don't understand anything. It's 2 to 6 weeks. So 7 weeks is already over. So it's not even hepatitis A she's suspecting. You understand? That's the NCLEX world. In the normal world, they can tell you the infection stage is 2 to 3 weeks and you start getting the symptoms 5 weeks after in the real world. You understand? But in the NCLEX world, if the woman gives you a week after the infection stage, you want to suspect that the woman needs education about that. Okay? So try to understand NCLEX world and real life situations. Don't interchange them, because if you interchange them and you are answering the NCLEX questions, you are going to answer them as though you were on the floor or as though it has happened in my house, and you will be wrong. So if they talk about fever and I want to relieve fever, I'm giving Tylenol. You are not giving ibuprofen. In the house, you see me taking ibuprofen because I have a fever, but antipyretic is more of Tylenol than ibuprofen. Okay, that's it, just by the way. Now we have hepatitis B. It's non-seasonal. Hepatitis B has no season. Hepatitis A infectious was oral, fecal, mouth, anus. So remember, contacting a person, and contacting a person can be all of the other hepatitis, but hepatitis B is blood-borne. We know that one already. I'm positive. and it affects all ages. It's not in children, okay? Me and you can get it anytime. I have a lot of things to explain about that. Now, the increased risk, there are some people at higher risk for getting hepatitis, IV drug users. You see all those smokes and the drugs on the street, they inject those heroin and those cocaine and whatever they inject. They're at an increased risk because they use needles that are contaminated. Most of them use the same needle for a couple of weeks, and they're at a risk of getting infected. And sometimes they share the needles among themselves. I don't know if you have ever seen that, but I have seen several people do that. So healthcare workers, you want to be mindful. If you are giving a patient an injection and that needle stuck you, you are at risk. You squeeze the blood off first, and then you rinse it under running water. NCLEX will ask that question. So if they ask, you want to run it, like you want to turn your finger like this and let the water run on it. And then you gently squeeze the blood. Not to just squeeze, it should be gently. Because so you run it, wash it off, wash the initial blood off for, I think it's like 15 minutes or so, how many minutes, or 5 minutes, something like that. You wash it off. So IV drug user, healthcare workers, hemodialysis patients. Now, hemodialysis patients are at increased risk because if a patient had hepatitis B that was not identified, and the patient sit on the machine and they get up, you come and sit down and they dialyze you. Remember, the hemodialysis use the osmosis diffusion principle to dialyze patients. So ultrafiltration process in the kidney that will take place is being done by the machine. So the machine plays the role of a kidney. So in the process of filtering, some of the virus can get attached to the portions of the machine. And then when you come and sit on that machine that is not clean enough or disinfected, you can get it. Now, patients are allowed to sit on the same machine with hepatitis, with HIV than hepatitis. Hepatitis is more dangerous in dialysis patients. It's more infectious in dialysis patients than in HIV/AIDS. So if you are HIV positive, I'm HIV positive, both of us can use the same machine. You can get up right now and I come to sit down, they clean the machine and I sit down. They don't have to disinfect the machine for a long time. And I come to sit down. But if it's hepatitis B, you have hepatitis B, I don't have hepatitis B, they can't dialyze us on the same machine. The reason being that hepatitis virus, when the virus is out of the medium, you know, like the medium, the host system, the ecosystem, if the virus is out of a medium for hepatitis B virus, if it's out of the medium, if it's out of the blood, and it gets stuck to this thing, if it's attached to this thing, it can stay for years. The moment it gets back into my skin that was tearing and bleeding, or body fluid, the moment it gets in touch with it, I get it. Can be 5 years, can be years or days, time. But HIV virus, the moment the virus come out and touch here, the person bled, and the blood touches here. Within 5 minutes, the virus is dead. So if after 10 minutes, I come in contact with my cut skin or my skin tissue or body fluid, I get in contact with this thing. 10 minutes after that, I don't get HIV/AIDS. So that makes hepatitis B more dangerous than HIV, just that sometimes we don't realize it. So a hepatitis B infection can be more dangerous than HIV/AIDS. Okay?
Okay.
Yeah. Then we have hepatitis C. Our time is up though. Hepatitis C. Hepatitis C is also mostly IV drug users. The mode of transmission is same as hepatitis B. So group them. Hepatitis A is fecal oral, anus to mouth. Hepatitis B is bloodborne. Hepatitis C is also bloodborne. When you look at the baby boomer generation, most of them got hepatitis C, and it's bloodborne. It stays. Incubation is 5 to 10 weeks. And to prevent it, I told you already, hand washing, needle precaution, screening blood donors, people donating blood. Like I told you, the baby boomers age, those are World War II people. Most of them that went for that war came back with hepatitis C. records will tell you that most of them came back with hepatitis C. So that generation, if one of them donate blood and they have to screen the person for hepatitis C. But right now they even screen all blood for all of that. And people who have hepatitis C and they are roaming around, you not think they have anything. Hepatitis D is called Delta agent. Now we have Delta variant of coronavirus. So it tells you that Delta has existed for years.
Excuse me, question. So this B and C, which one of them has is body fluid apart from blood, like semen
C.
and
B.
C, right?
C.
B.
C and B, they are both the same.
Okay.
They both have same problem. But when you talk about blood, semen, when you talk about blood, some books will tell you sexually transmitted, which is hepatitis B. Hepatitis C is mostly body fluids in contact with the person. Am I right? Does it make sense?
Yes.
Yeah, so when you have body fluid like semen and blood, you want to think equal like HIV, the same way, and it's hepatitis B. But
I noticed-
huh?
I said, I noticed too in hepatitis B, it can also be transmitted through saliva.
Yes.
While they mentioned that HIV is not something that is carried through the saliva.
Yes.
That is serious.
Yes, that's true. HIV is not more of saliva. So if somebody spits in your face, your risk for getting HIV is like nothing. But your risk for hepatitis B or C is high. Their body fluids. Okay? Their body fluids. Like I told you already, if somebody spits in your face, you wash it off, you're fine. But if somebody spits in your face and it stays for 5 minutes and the person even has HIV, I don't even think the HIV virus will be there. So mostly HIV will limit it to sexually transmitted. That's why it's being counted as STI. And mostly hepatitis B, they just talk about it with other hepatitis viruses. And they don't focus too much about sexually, but semen and blood is hepatitis B. And hepatitis C has the same signs, the same risk for infection. And transmission is the same as hepatitis B.
Okay. Both of them are
contact.
contact.
So both of them are the same. Yeah.
They're contact. All three of them now. Are they all contact? Because I know that A is contact.
So A is fecal oral. You get in contact with fecal oral. You get it. Yes. The two are contact precaution. So you use contact and standard precaution for all of them. Okay.
Thank you.
Standard precaution goes for everybody. So to be more specific, is contact. It's not droplet, it's not airborne, it's contact. Okay. And I'm done with this. Blood donors should be screened as well. Now, Delta hepatitis is hepatitis D. Hepatitis D is mostly in the Middle East and Mediterranean regions, areas of the world, they have it. It only occurs when the patient has hepatitis B infection. It's usually considered as when the patient has hepatitis B infection. That's when you get in contact with the Delta agent, then you get hepatitis D. So hepatitis D is more like dependent on you having hepatitis B. Then it manifests based on your location. So it's more of a location thing than just an infection. So if I'm here in America, I may not be thinking about it so much, even though I know it exists, but I'm not so worried. So questions that NCLEX can present with you to direct your mind is they will tell you the patient came from Mediterranean area, or the patient came from the Middle East last week. You understand? So they give you a scenario and they give you the transmission period. The patient travels within this period. That's the incubation period. And they let you know what happened. So when that happened and they are talking about hepatitis and they tell you traveling to Middle East or Mediterranean area, you want to think is hepatitis D. The patient already had a history of hepatitis B. that will manifest hepatitis D in the person. So because hepatitis D must coexist with hepatitis B, the precautions that help prevent Hep B are also useful in preventing delta hepatitis. So complications is chronic liver disease. That's it. So take hepatitis D as dependent on hepatitis B as well, okay? So the mode of transmission and everything will look the same, because if you have hepatitis B, it just kind of like complicating or adding the second hepatitis to it. Now, hepatitis E is waterborne virus. So that one is the same as hepatitis A, fecal oral. So this one is more oral because we drink the water, right? We don't drink our poop or our pee-pee. So we don't talk of fecal, but it's oral. So we're going to talk about waterborne virus. That's hepatitis E. So we get that one from.
That would be something that's associated with like E. coli and stuff like that.
Yes. So when you eat some vegetables, when I was mentioning the point, it says something about the vegetables too.
Yes.
That will cause those hepatitis. So E and A, relate them together to present same symptoms. But here, they are more specific about symptoms of people with people who are pregnant in the 3rd trimester. They have a high mortality rate. That means their recovery rate if they catch hepatitis E is less. And people who have traveled to India are at risk too. So if you are from the Indian descent or you travel to India, Algeria, Mexico, or Burma, you are at increased risk for hepatitis E. So they can also refer to this as the traveler's hepatitis.
Okay.
So NCLEX will not mention hepatitis E, they will tell you traveler's hepatitis. Or the patient traveled to India and came back, and within 6 weeks' time, the patient started manifesting. What kind of hepatitis they want you to be able to know is hepatitis E. It's waterborne. They will ask you, what do you think the patient would have done? Probably the patient drank some water that was affected with the virus, or that was not treated well. So NCLEX will twist it and put some words like that just to get you. You need to know the kind of hepatitis. So incubation period is 2 to 9 weeks. Complication is mortality in pregnant women, that's death and fetal death. So if pregnant women are more at risk for this hepatitis E, getting a serious effect of it. So pretty much that's it. We have, I'm going to stop here. I have pancreatitis. I was just going to finish up ulcerative colitis, Crohn's disease, and the last one was diverticulosis.
That's
And
something that we see a lot of though.
Is there?
The diverticulitis.
What happened?
It's something that we see a lot.
You want me to go into that?
Yeah.
Okay. And then I also added medications for abdominal, only stomach medications that NCLEX can dig into. Yeah. So diverticulosis, that's herniation of the intestinal mucosa, mostly in the sigmoid colon. Now, let's go back to our picture. So this is a picture I'm using for you guys to see. Herniation of intestinal mucosa in the sigmoid colon. What is the sigmoid colon? We see that here.
Mhm.
So herniation of okay, sorry. Herniation of intestinal mucosa. So the lining inside the intestine, the large intestine, it protrudes into the colon, into the sigmoid colon. So you see it form like a little bump. So it pushes it like that into the lining, the mucosal lining, it pushes inside it. So inside the patient's colon, inside the large intestine. So I assume that this is a hole inside, this is inside the large intestines, right? So the thing will, and the lining is here. So this one will protrude and it will have a little bump. Just like the way you see a pimple or an abscess protrude on the skin, you see that one bump out. So something will cause it to push out. I don't know if we are getting the explanation I'm trying to put across. If you have a hollow substance, I don't know how to describe it better, but if you have a hollow substance here, so this is inside the large intestine, and you have a little, the lining is here, so the skin is protruded inside through
Like
it.
forming like a balloon, small
It
balloon.
forms like a balloon, correct? Like it goes over, and it's inside the colon, it's inside the large intestine. So it's part of the intestinal lining that is protruded. So that means something has caused it to protrude. Now let's go back to our notes and continue from there. So protrusion into the large intestine. And then we have diverticulitis, that's inflammation of the diverticula. So the diverticula is the one that is lining inside the sigmoid colon, inside the large intestine. So if there's a protrusion in it, it will cause inflammation. So if there's inflammation, there'll be leakage of fecal matter. So instead of having the large intestines release the stool that has gone around the stomach to the sigmoid colon, ready to exit through the rectum, it now come, and then there's a balloon that has formed that has created space. So it's now leaking inside that one. It will cause inflammation. So if the whole process is inflamed down there in your stomach, where do you think you have the pain? That's my question to you guys. Look at this picture and tell me where the patient is likely going to point the pain at. If you are the nurse for the patient, where will the patient show you the pain is at?
In the lower, around
Lower
the
abdomen.
Lower right, lower left. We have to be specific.
Lower-
You see the whole
lower left.
thing? So if
Lower
the
left.
patient has appendicitis, I expect the pain to be on the lower right.
Lower. Yeah.
But if it's diverticulitis, I expect the pain on the left
Right.
lower quadrant of the stomach. You see where it is? So that's why I'm showing you this picture, so that you know where the structures are located. NCLEX wants you to be able to identify the problem by the sign or the location the patient is going to point. Okay? So if the patient points a left upper abdominal quadrant pain, you want to think the liver is there, gallbladder is there, the bile is there. Those are the structures you want to think. The patient pointed in the middle, epigastric, upper middle stomach. You want to think the esophagus and the stomach itself. You understand? So that's how NCLEX will present to you. They give a scenario and they make the patient come to you to describe the location of the pain without telling you where the pain is at. So you need to know the location of the abdominal structures as well. That's why you look at the picture. That's why I'm showing you that picture. Because if you don't know the location of the structure itself, you've already not understood the question because you can't find it. Now, signs and symptoms will be lower left abdominal pain, intense with coughing, straining, or lifting. So you pick up something small, you have severe pain. You cough, you have pain. Your temperature will be elevated, that's fever, nausea, vomiting, flatulence. You'll be passing gas because it's closer to your rectum, and that's where there's the exit. So you start passing out gas. Then cramp-like abdominal pain, tender distension. It will be tender around that side. So when you check the stomach, you feel rebound tenderness and distension. There'll be blood in the stool because there's inflammation. The lining is affected. So blood vessels are also affected, and then blood joints. When you are when the whole digestive process, or when the waste product gets to the sigmoid column about to exit through the rectum, then it gets blood stain from there. Okay, I had a patient with that yesterday who was bleeding heavy. He was bleeding. I don't know if, okay, he was bleeding very heavy. And then I have blood in stool. I already said a rectal palpable mass. So when you put your hand inside the patient's rectum, you'll be able to feel it because it's right close there. You have to put your hand deep. Probably my whole finger has to go in before I can feel it. Okay. So when you put your hand inside the rectum, you'll be able to feel it. Now, mostly it's surgical intervention besides dietary management and anti-inflammatory medications. So anti-inflammatory medications can be for abdominal disorders. I have that in the medications. We have anti-inflammatory medications used for abdominal disorders. So abdominal disorders that are inflammatory process, you give the right medication for the abdomen and you add anti-inflammatory. So don't be surprised when they give patients anti-inflammatory medications as well for abdominal problems. So the colon, now comparing diverticulosis and hemorrhoids, no, not hemorrhoids, hernia, yes, diverticulosis and hernia, they are both protrusion. You understand? The difference is that in hernia, the protrusion is in an organ that will show outwardly. But in diverticulitis, the protrusion is to the lower part of the large intestine, the sigmoid colon, and it's inside the sigmoid colon. It's not outside. So if hernia is hiatal hernia is here, it can cause a protrusion here. So I can look at you and then it looks something big. Umbilical hernia, I know we would have all have seen umbilical hernia, especially from children. You see the umbilical hernia will protrude. So those ones protrude into organs that will come out of the body. But the diverticulitis, the protrusion is inside the sigmoid colon, inside the big intestine or large intestine. So you won't see it outside, but the symptoms will be able to tell you. And when you put your hand under the patient's arms, you'll feel it. So usually it's bowel surgery. They'll do colon resection, anastomosis leading to temporary or permanent colostomy, and may be required for increased bowel inflammation. So if there's increased bowel inflammation after they have tried to let the patient minimize certain food substances, minimize aspirin that can cause all those things, those bleeding effects and other symptoms, you try the non-invasive management first. And if all that doesn't work, then the patient has to be on a permanent colostomy for bowel movements. So that's why the patient will always walk with a bag to poop. And remember, we have urostomy too, and urostomy goes to the urinary bladder. And those things can use the same bag, the same stoma size, and all those things. They can share stuff, but one is draining urine, one is draining stool. Anything stomach is draining.
Yes.
Okay.
So at that location, what will it be called?
What?
Not ileostomy, it's sigmoidectomy, otomy.
What's it? You say what?
If the stomach is created around that sigmoid area, that's it will be called sigmoidectomy, otomy.
That's if
I think it's
cutting,
ostomy.
yeah, it's ostomy. That's creation of a hole. But it can be sigmoidectomy because they are cutting through the sigmoid colon. So if they're cutting through that, it's sigmoidectomy. But at the end of it, because it's the main name they use is the colon. So they refer to it as colostomy. So the one they'll now be putting the bag on will now be on the colon because they will cut the sigmoid area off. And then they will use they will anastomose it, they'll pull it down, and then they join it with the abdominal tissue and they create the hole for the poop to be draining. So now it will become colostomy because the sigmoid is gone. The sigmoid colon is gone. It's now left with the colon alone. So the hole will be created on the colon. So the sigmoid is cut off because that part was diseased. Do we understand?
Yes.
Yes.
So then in that case, like patients who have a colostomy bag, what are their chances of developing diverticulitis?
Diverticulitis. I thought I already explained that. Diverticulitis is inflammation. Diverticulosis is herniation of the intestinal mucosal lining, mostly in the sigmoid colon.
So that's what I'm, if the patient with a colostomy bag, you just said that the sigmoid colon is would be taken out for them to do the, for them to have the, make the hole for the, to pass the waste. So
Yeah.
I'm saying in a case like that, when the sigmoid colon is not there, will they,
Then-
could they still develop diverticulitis?
It can still be another formation within the
Okay.
large intestine, but no
Okay.
longer the sigmoid colon. It can be any portion near there, can be
Okay.
any part of the large intestine. So most of those stomach, where I was going to start, that diverticulitis will be inflammation of the lining of the diverticula. So the same lining that is left in the whole large intestines can get inflamed at any point.
Got
So
it.
if it get inflamed and then it's not healing, it's continuous, then they keep cutting your abdomen. They keep cutting those portions. So I had put it down that Crohn's disease is inflammation of the GI tract, mostly in the ileum. This is another thing I see NCLEX always asks, is usually in the ileum. Crohn's disease, that one is usually in the ileum, and it can cause thickening, narrow lumen, and fistulous ulceration and abscess. That's what it can cause. So they can put a fistula in the end around the ileum. Now, so let's look at where the ileum is. So when you talk of Crohn's disease, we are looking for our ileum.
Which
So
is in
our
the
ileum is in the small intestine. I wanted to show you guys something here. I think I'll just send this note for you guys to go over it within the week so that we are done with GI tract, okay? You can go over the lower part of what is left. I wanted to show you something specifically here. You see the appendix? Most often, science have not been able to prove a major serious function of the appendix. That's why anytime there's inflammation, I have appendicitis that I didn't tackle. Anytime there's a problem with the appendix, they just cut it off and it doesn't affect you, okay? They just cut it off. Probably God just designed it to be the end, to seal the whole thing. But its function is not seriously noticed. It's not seriously being based upon. But it's always a serious problem, especially if it ruptures, fluids start leaking into all these structures and it can cause peritonitis. So this is the appendix. When there's a rupture in there, it starts leaking fluid from the bowel, from the large intestines. And then it can cause peritonitis and it's usually an emergency surgery. So pay attention to that. I think I'm done with appendicitis too. But I wanted to tell you guys that when the food enter here, it goes round. This is the small intestine. It goes in and out, and it comes to join here. The iliacal junction, that's the one that delivers the food to large intestine. So the large intestines pick the food from here, and then it also start working with it, and it goes round like this and come and exit here as poop. Okay? So mind the junction here. When the patient is complaining of pain and they say the pain is in the iliacal junction, especially for the LPN exam, they can go straight with content about questions like this. They want you to know where the organs are located. So if it's in the iliacal junction, then it goes straight. It's closer to appendix. So it's in between the ascending colon and the appendix. That's where you have the iliacal junction, or not appendix, the cecum. So the cecum and the ascending colon in the middle is where the small intestines deliver its content. That is pasty, because the stomach digests and it becomes liquid. So all the small intestines carry liquid stuff, and all those liquid stuff are emptied into the large intestine. Now, if there's a backflow into the small intestines, there's a problem. So where the food enter here is not supposed to return back here. It can only go in here. It doesn't allow backflow. So where there is a backflow, you can imagine what will happen. So this one is trying to bring more. This one is backing up. Your stomach will feel full and you have abdominal pain. And that pain, you will locate it. Let me check and get you the condition. I have a condition for that. You have pain there. So I don't know if you guys have questions that you use to practice with abdominal disorders, but this is a good way for you to be able to put it into practice if you happen to have questions that will base mainly on abdominal disorders. It will help you in your practice and how you answer the questions. So looking at this picture, if you can take a picture of the picture, or if you want, I can put it in the Google Classroom and you go and view it. You have the picture in mind. You may not be able to remember all the structures, but sitting down, I remember that the large intestines cover like this, and the small intestines are in the middle. And I remember that some are on the right, some are on the left. So patient complaining of left side pain, I start looking for appendix, I look for ascending colon and all those things. So especially for the LPN, those are the things they will want you to know, because most of the questions, besides the higher level questions, sometimes they add straightforward content questions. So don't ignore it. And even if they add a straightforward content question, sometimes they twist it to confuse you. You will not even know it's straightforward content questions because they just put some stupid stuff. And like I told you, some of the things doesn't even make sense, but they just put it there to confuse people. So most of those abdominal surgeries, if the surgery is related to any of these portions, they will end up cutting it. So if they cut a portion of the intestines here, they'll pull one here and pull one here and they put it together and join. That's anastomosis. So if they come to cut here because the descending colon was having the inflammation inside, then they pull one portion and they pull one portion, they join it. If they cut a portion here, then they pull a portion of the stomach and they do it. That's where we have the BROF 1 and BROF 2. I had mentioned that in the beginning. I don't know if you remember. So if they cut between the duodestomy or the duodenum and the stomach, if they cut this portion off, then they're going to pull the duodenum straight to the stomach, the anastomosis. So if they cut the jejunum, then here, they pull here and here, your stomach is shortened. So they cut that off and then they join it and that becomes gastrojejunectomy, BROF 1, BROF 2. So BROF 1 has to do with the duodenum, BROF 2 has to do with the jejunum. Any question?
I think we are okay.
Yeah, like I was telling you, the NCLEX people are not stupid. I know people think it's all about answering questions. Yes, it's good to answer questions, but how much questions can you answer if you don't understand? There are people, there are intellectuals who said these questions. They know that all you think is answering questions, But mind you, if you don't know the contents, if you don't understand, maybe you manage to pass your A&P in school, that's fine. But if you don't know this content and you go and sit in that exam, it doesn't matter how many questions you answer, you are going to flop. And to be able to have this in mind, you don't need to know all these symptoms. Nobody is ever perfect. You will never get 100% perfect. And you don't need 100% to pass these exams. It's a life-changing exam. It's an exam that will challenge your thinking capacity. So because it's an exam that will challenge your thinking capacity, get a picture in mind. So if you come with abdominal pain and they tell me it's pancreatitis, I know the pancreas will be inflamed. I will tell you not to eat spicy stuff. You will start losing weight because when you eat, you have this burning feeling, you'll be regurgitation. So you look for abdominal problems and then you associate it. And abdomen also has to do with vitamins, so you educate patients. So your patient teaching should always be geared towards helping the patient to stay still, especially for those that are chronic stomach problems. Most people didn't even know hepatitis is part of GI problems. I don't know where some nurses always think, but personally, growing up as a nurse, when I first started in Ghana, I used to think hepatitis was never part of stomach. It took time. Every time I'll go and read hepatitis A, B, C, D, and I'm still confused as to what it is. Take it in mind, the mode of spread. And when they're talking about communicable disease right now, flu-like symptoms. Thank God for COVID. Now I know we all know the symptoms. COVID will always present. If you're not careful, you think COVID is flu until it's diagnosed. So most often, the differences that will be in between all these problems will be diagnostic tests, because they all present similar symptoms. I don't know if they've updated the exam for COVID yet, but I haven't seen anything that they talk about adding COVID. But remember, we had Corona before COVID-19 came. So all those things are already covered under communicable diseases. Okay. So Simone, I'm going to have you check out the things I posted in the Google Classroom. And if you can get questions related to GI, I don't have questions specifically for GI to answer. The questions I try to give general questions for every week. And like I told you guys, I'm not so crazy about it because I know you have answered these questions over and over, especially if you have sat for that exam before. I know you have answered it over and over. I'm not really too crazy about it, even though that's what you need to know. You need to be able to implement all what you are learning now into answering questions. It will not do you a favor, or it will not help you if you get in all these things and you are not testing yourself to get more of it. Okay? Because I can only present it to you, but you need to be self-disciplined. Like I told you guys in the first day, my mission is of the fact that people need to understand before they go and sit there. The people that set the questions are not ignorant. They are highly learned people. They know where to get you. So they bring out the content from the book and they twist it in a live practical manner and bring it back to you. Then you are used to eliminating answer choices. It gets to a point for Freddie. It gets to a point in the exams that you just don't have an idea about what an answer should be. You just don't know, because like I keep telling you, you are never going to know everything before you go inside the exams. But you need to be able to pick up one or two words in that question that will make sense to you. If the answer choices don't make sense to you, just eliminate those that don't make sense to you and look for the one that you think is more closer to the topic they are talking about. Okay? And I'm working on a document for EKG rhythms and strips. So
okay.
when I get it, I will chip it in one of the days. So I'm not going to go back to GI, okay?
Okay, the EKG, I remember there was one question that they brought the EKG script and they asked to select or that apply, like it was in the form of doing, like if you identify the script, then they ask you what are the steps you're gonna do
Manage.
to solve that problem. Yeah.
Yes.
It was more than, it was select or that apply.
Yeah. Is that the one you posted on the platform?
No, that is different.
Okay. I remember in my NCLEX, so I got a question like that. They give you the EKG. The information they describe is describing a certain rhythm, and you should be able to identify the rhythm. It was a case scenario they gave me. You should be able to identify that particular rhythm. And when you identify that rhythm, then you should be able to know what management is worth it. What is the right management for it? I think mine was AFib, and they wanted to know what I would do in the case of AFib. And if the case advanced, if it did not respond to the management, what was the next step? I think it was another question. But most of the EKG readings and the EKG strips will present to you direct forward questions. And if I tell you the medication calculation questions, if I ever remember what I got, they were straightforward calculations. I could just use my phone to divide that medication. They're giving me tablets and they want to know how many milligrams. They're giving you straightforward calculations. It's not like the school one that the school would be tricking your mind to calculate difficult drop rates per minute and all those things. No. So relax about the exams. Don't feel like it's an exam that has not that is there to drain you. It's just there to challenge your thinking. But it's not that you cannot make it. It's just that there are some things you are not understanding. So think simple and make sure you know this content. And when you read a question that's talking about the content, you start figuring out the answers from there. Clementina.
Yeah.
Can do this.
Hmm?
I said, I know we can do this. Failure
Oh,
is not a
sure.
choice.
Yeah, we can.
Yeah. Failure is not a choice.
Thank you very much.
Okay, so I couldn't go over the book with you. I have a book that I put together the information. I think I need to put the software and send it out. I printed it out on my paper and I'm reading it out to you. But the other one that I posted on the classroom is different documents, and that one too is a lot of it's voluminous. It covers everything. And these are people that have gone into the enclaves and they came out to also state things they have seen. I have that one separate, but this one I'm posting to you, just try to know them and make it like daily reading. Put it on your phone. That's why I prefer the Google Classroom, because if I have my phone, even though if I'm going to post stuff to you guys, I'm limited to what I can post with the phone. But if I want to post and review stuff, I have to come to the computer. But if I just want to open and read stuff on it, I use my phone everywhere I go. So I like the user friendly, because we're in a new world. So try to make good use of that. I'll be posting a lot of stuff in there. I don't know if you want me to send you this document, I should post it in Google Classroom. Should I put it in Google Classroom?
And in the group chat.
I don't want you to get comfortable in reading it. I want you to know that if you don't read it at a certain time, you lose it. That's my aim. Because sometimes you have to limit students, you know. If I give it to you, you get comfortable, you're like, okay, I'll read it the last week. But I want you to run at a certain pace. After this week, you should be thinking of becoming a master in answering abdominal questions that relate to abdominal problems on the ankles. You should be moving to that direction. You shouldn't be going back to reading content. Okay, so should I put it in the Google Classroom?
Yes.
Yeah,
Yes.
I'll put it in the Google Classroom so that you pay attention and then you read it. But just in case anything you have to share, you can always post it on the platform. I have one of my colleagues who joined us, the unknown person that joined us. He texted me that he joined the line. He just wanted to see how we're doing, and he thinks you guys are responding good. So if you have anything to post, anything to say, any question, anything I'm doing that is not right for you, just email me. Don't be worried. Okay. Yeah, I'm a free person. I don't take it personal. So if it's not working right for you, just let me know. Okay.
All right.
Because I understand that it's not easy with this exam, but it takes the knowledge of your stuff. So I believe in knowing what you're doing before you can talk. Okay, so good night. I'll see you Monday, right? And I'm going to
Yes.
try to work on the answers for the exam. Since we're having a challenge, I'll just submit everything to you guys all over by the weekend. I'm pretty busy this week. They put me for 4 days and I've been wild because they had joint commission and it's been busy. Yeah. So I'll try to get it to you guys by weekend. Okay. Thank you so much for coming, and always text me, email me, WhatsApp me, whichever one. I'm on it 24/7. As soon as I see, I give you a reply. Bye-bye. Good night. Good night. Simone,
Good
is it going
night.
well with you?
Yeah, good night. Thank you.
Yes.
Okay.
Yeah,
All right.
thank you.
Okay. Bye.
Good night.
Good night. You're fine. Jennifer.